Our population here in the Bronx is special. We have patients who often are a first generation from another country so there's a population of patients that come from countries where they may have had rheumatic disease early in their life, and now in their adult life it's affected their heart valves, and then they're becoming pregnant, so it can be a very complicated situation. In the Bronx, we also have patients who may not speak English. English is not their first language, and again, they're new immigrants to the United States, and may not have accessed health care in their country, and now they're pregnant, and now this is the first time they're accessing health care. So there's a whole realm of medical problems that we may discover in their pregnancy, which makes life very complicated for them. In my office, I see on average about 10 patients in an office session, but at a given time, I'm probably taking care of perhaps there's 40 or 50 pregnant patients that I'm looking after, but probably not just by myself. So for the cardiac patients, I'm looking after together with the cardiologist. Some of them I'm looking after with colleagues of mine. So we have our high-risk offices are in different parts of the Bronx, and there are different populations within the Bronx that access different locations. So we try to coordinate amongst one another so that we can bring those who have cardiac disease to the MFM Cardiology Joint Program, but they can still continue their obstetric care where it may be convenient for them. I appreciate that question very much because I've thought about it myself. And when I first read that, I thought, oh, it's because women are having babies when they're older, more people are obese in the United States. But the study that reported this fact controlled for all those confounding factors. And so we can't blame it on that. I think it's a few reasons. One is that, yes, we have improved tremendously at preventing death from hemorrhage, preventing death from hypertension, preventing death from infection. These are what causes death in sub-Saharan Africa, unfortunately. And it's really, I've done global health work. That's one of my main interests. And I can tell by personal experience that, there's not enough blood products available. There are certainly antibiotics to treat infection, but there's different microbes that we're dealing with depending on what country you're in. And hypertension in pregnancy, in the United States, we're very conservative for the most part in most of the United States about how we treat hypertension in pregnancy, and that is that we deliver pregnant patients in a timely fashion before they get really sick to cause death. Whereas, again, from personal experience, in other parts of the world, there may not be a system in place for fetal testing, for maternal monitoring, to develop delivery plans in a timely fashion. And I'm actually part of a group that's trying to improve that effort, specifically in different countries in sub-Saharan Africa. But in the US, I think that explains some of why cardiovascular disease has become number one. Here at Montefiore, our department has a specific liaison with the medical school in Rwanda, in Kigali, as well as in Ghana, in Accra, Ghana. So those are the two places where I've been part of a group of us who've worked there. Very different conditions, and I've actually seen some cardiac disease in pregnancy there, and what it tells you is that we're all human, we all have the same disease and situations, but we don't unfortunately have the same resources, and therefore one has to be very creative about how they manage patients.